Murmurs. Sudden declaration of blood produces heart sounds. Heart sound murmurs are produced by turbulent flow in which Reynolds number is greater than 2000 across an abnormal valve, septal defect or outflow obstruction, or by increased volume or velocity of flow through a normal valve. Murmur may occur in a healthy heart. These innocent murmurs occur when stroke volume is increased, for example during pregnancy, and in athletes with resting bradycardia or children with fever. Now, mechanism of murmur. The first mechanism is blood viscosity or velocity. Changes in blood viscosity or increased flow velocity, for example in anemia, fever, thyrotoxicosis, create turbulent flow that produces murmurs. Second mechanism is valve abnormalities, where narrowing or stenosis. A narrowed valve forces high velocity turbulent flow across the orifice during systole or diastole, producing a stenotic murmur. Third mechanism is incompetence, valve incompetence. An incompetent valve permits retrograde flow during the wrong phase, creating a regurgitant murmur whose timing depends on the valve involved. Organic versus relative valve dysfunction. Organic lesions or structural valve damage cause intrinsic murmurs. Relative dysfunction causes functional murmur without primary valve disease. Abnormal connections or shunts or fistula. Direct communication between high and low pressure chambers or vessels. For example, patent ductus arteriosus or arteriovenous fistula or ventricular septal defect produce continuous or hollow systolic murmurs from persistent turbulent flow. Next is vibration of loose structures. Mobile or flail leaflets, chordae, or intracardiac masses cause extra vibrations. For example, tumor plop or musical murmurs that are audible as murmurs. Next mechanism is vessel diameter changes. Local narrowing or stenosis or dilatation or aneurysm or high flow enlargement alters flow patterns and velocity, producing murmurs or broods over the vessel. Now next is grading of systolic murmur, given by Freeman and Levine. Grade 1 is very faint, grade 2 is quiet but hard immediately, grade 3 is moderately loud, grade 4 is loud with thrill, grade 5 is heard with stethoscope partly off the chest but thrill is present, grade 6 no stethoscope needed but thrill is present. Now, features to be observed in heart murmur. First is timing. By continuous palpation of carotid arterial pulse and note whether systolic, diastolic and continuous murmur is it. Next is shape. Crescendo grows louder, decrescendo decreases. Next is crescendo, decrescendo and then plateau. Now third feature to be observed is intensity. Systolic murmurs are graded on a 6-point scale given by Levine and Freeman, which we discussed. Diastolic murmurs are usually not graded but can be described as very soft and loud with or without thrill. Next is duration. Location of maximum intensity depends on the site where the murmur originates. Next is character, blowing or harsh or rumbling and musical. Pitch can be high, medium, low depending on the velocity of the jet. Next is radiation or conduction. Reflects the intensity of the murmur and the direction of blood flow. Mitral regurgitation murmur or presystolic murmur radiates to axilla. Aortic systolic murmur, extrasystolic murmur conducts to the carotid. Variation with respiration or position or other maneuvers. Next is best heard with bell or diaphragm of stethoscope. Now we will discuss the systolic murmur. Systolic murmurs are ejection systolic or various systolic murmurs. Its another name is mid-systolic murmur. Ejection systolic murmur or mid-systole murmurs occur when there is ventricular outflow tract obstruction. It begins shortly after the first heard sound and ends before the second heard sound with a crescendo-decrescendo or diamond-shaped pattern reflecting the changing velocity of blood flow. Now, various systolic murmurs and its causes. Various systolic murmurs and its causes. The first one is early systolic murmur, small ventricular systolic ventricular septal defect, small ventricular septal defect or large ventricular septal defect with pulmonary hypertension. Harsh early systolic murmur from high velocity flow across the septal defect. Or acute severe mitral regurgitation, early systolic blowing murmur from sudden regurgitation into the left atrium. Next is acute severe tricuspid regurgitation, early systolic right-sided blowing murmur from the sudden tricuspid incompetence. Now, late systolic murmurs. Late systolic murmurs, the first cause is mitral valve prolapse, where the late systolic crescendo murmur with this mid systolic click due to leaflet is billowing. Next is tricuspid valve prolapse. Late systolic murmur similar to mitral valve prolapse but heard best at the lower left sternal border and accentuated by inspiration. Papillary muscle dysfunction. Late systolic mitral regurgitation murmur after ischemia or infarct when papillary muscle fails, often with acute pulmonary symptoms. Next is mid-systolic or ejection systolic murmurs. Aortic stenosis, which are harsh crescendo-decrescendo ejection murmur, peaking mid-systole at the aortic area radiating to the carotids. Next is pulmonary stenosis, ejection systolic murmur loudest at the left upper sternal border, increases with inspiration. Hypertrophic obstructive cardiomyopathy, dynamic mid-systolic murmur is there that increases with maneuver that reduces left ventricular volume, for example Valsalva or on standing. Pansystolic or holosystolic murmurs. Mitral regurgitation, holosystolic blowing murmur best heard at the apex, which radiates to the axilla. Next one is tricuspid regurgitation, holosystolic murmur at the lower left sternal border that increases with inspiration. In ventricular septal defect, harsh pansystolic murmur is present at the left sternal border from left to right flow across the defect. Rarely, early patent ductus arteriosus or patent ductus arteriosus with Eisenmenger persistent flow may produce a pansystolic like component troponin patent ductus arteriosus, which typically causes continuous murmurs. Now, use timing early, mid, late, pan, location, radiation, and respiration position effects to distinguish these systolic murmurs in the ward. Next is various diastolic murmurs and its causes. The first is early diastolic murmur. Early diastolic murmur can be aortic regurgitation, where early decrescendo diastolic murmur is best heard at the left sternal border, which radiates to the apex. Now, pulmonary regurgitation, early decrescendo diastolic murmur at the left upper sternal border, often high pitched, known as Graham Steele. In pulmonary hypertension. Next is mid-diastolic murmur. Mid-diastolic murmur in mitral stenosis, classical low-pitched rumbling mid-diastolic murmur with opening snap at the apex, louder in the left lateral position is heard. In tricuspid stenosis, Mid-diastolic rumble at lower left sternal border, which increases with inspiration. In the Caricom's murmur of acute rheumatic fever, where soft mid-diastolic murmur of acute rheumatic fever from inflamed mitral leaflets is heard. In Austin Flint murmur is a mid-late diastolic rumble at the apex in severe chronic aortic regurgitation due to jet impingement on the mitral valve. Flow-related mid-diastolic murmur. High output states such as anemia, thyrotoxicosis, pregnancy produce a flow mid-diastolic murmur across a normal mitral valve. Mid-diastolic murmur across mitral valve from mitral regurgitation, aortic regurgitation, ventricular septal defect, patent ductus arteriosus. Here, altered diastolic flow patterns where from these lesions may produce a mid-diastolic component. Mid-diastolic murmurs across tricuspid valve from atrial septal defect or tricuspid regurgitation produce right-sided shunt or regurgitation which increase diastolic tricuspid flow which produce a rumble. Atrial myxoma or ball valve thrombus. Mobile intracavitary masses intermittently obstruct atrioventricular inflow producing a tumoral mid-diastolic rumble or tumor plop. Core triatriatum. A membrane dividing the atrium causes obstruction, inflow and mid-diastolic rumble. Now right-hand murmur. Atypical mid-diastolic murmur described with complete heart block and slow rates. Next we will discuss about late diastolic or pre-systolic murmurs. Here in mitral stenosis or pre-systolic accentuation, rumble intensifies just before S1 due to atrial contraction across stenosed mitral valve. Tricuspid stenosis. Similar pre-systolic accentuation at the tricuspid area with atrial contraction is heard. Myxoma pre-systolic effect. Atrial tumor may cause pre-systolic sounds when it intermittently obstructs the valve orifice. Now use the bell at the apex for mitral mid-diastolic murmur. Left lower sternal border for tricuspid mid-diastolic murmur. Look for opening snap and loud S1 for mitral stenosis. Respiratory variation for right-sided lesions and a tumor plop for atrial myxoma. Always follow up suspicious diastolic murmurs with echocardiography as it is diagnostic. Now we will talk about continuous murmurs. Continuous murmur is a murmur that begins in systole and continues without interruption, encompassing the second sound throughout diastole or part of diastole. Now we will discuss about the causes of continuous murmur. The first cause is systemic to pulmonary communication. Systemic to pulmonary communication, for example, patent ductus arteriosus. Classic continuous machine-like murmur from aortic to pulmonary flow is seen. Aortopulmonary window, large congenital aorta, pulmonary defect produces continuous flow noise. L kappa, anomalous left coronary from pulmonary artery, coronary pulmonary shunt physiology in infants with continuous flow and ischemia. Next is tricuspid atresia with collateral shunts. Collateral systemic pulmonary flow can create continuous murmurs. Truncus arteriosus, single arterial trunk with continuous pulmonary flow produces a continuous murmur. Next is surgical systemic pulmonary shunts Waterson POTS or Blalotoxic. Palliative shunts after tetralogy of flow generate continuous flow sounds. Next is systemic to right heart connections. Coronary arteriovenous fistula. Direct coronary artery leads to cardiac chamber fistula, creates a continuous murmur and volume overload. Ruptured sinus of Valsalva into right heart. Acute aortic leads to right-sided shunt, produces an audible continuous murmur. Now left atrium to right atrium connection. Lutem-Becker syndrome, where atrial septal defect and mitral stenosis both are present. Left to right atrial flow from atrial septal defect can add continuous or systolic diastolic flow features. Next is arteriovenous fistula. Systemic arteriovenous fistula, which can be traumatic or congenital. Large arteriovenous connections produce continuous bruit or high output signs. Pulmonary arteriovenous fistula, continuous pulmonary shunt, causes flow murmur and may produce hypoxemia. Now normal flow through constricted arteries. Coarctation of aorta. High velocity flow across the narrowing can produce a systolic, diastolic or continuous bruit. Peripheral pulmonary stenosis. Persistent high velocity pulmonary flow creates continuous noise. Renal artery stenosis. High velocity renal arterial flow may present as a continuous abdominal bruit. Next is increased flow through normal vessels. For example, esophagus and hums. Cervical venous hum. Benign continuous venous hum common in children and young adults. Cruville Baumgarten murmur. Continuous epigastric venous hum from portal hypertension with recanalized paraumbilical veins. Mammary or uterine souffle. Continuous arterial sound from increased flow in pregnancy or lactation. High flow lesions or tumors. Thyrotoxicosis, hepatic cell carcinoma, renal cell carcinoma. Tumors or thyrotoxic and arteriovenous shunts create continuous arterial murmurs. Now, the presence of systolic diastolic murmur, so-called to and fro murmur, is not a continuous murmur. It is separating the two murmurs through a small silence. It involves two components: a systolic and a diastolic one, in which the blood flows in the opposite direction. In contrast to true continuous murmurs, blood flows in the same direction in both systole and diastole. To and fro murmurs are two murmurs that occur through a single channel. Now, causes of systolic, diastolic and to and fro murmurs. Systolic diastolic murmur. First one is ventricular septal defect with aortic regurgitation. Combined systolic ventricular septal defect flow plus diastolic aortic regurgitation produces audible sounds in both phases. Harsh systolic murmur at the left sternal border with a decrescendo diastolic aortic regurgitation. To and fro murmur, distinct systolic ejection plus diastolic regurgitant component. Now, aortic regurgitation with aortic stenosis. Harsh mid-systolic ejection murmur from the atrial stenosis, followed by an early decrescendo diastolic murmur of aortic regurgitation, which is a classical to and fro at the aortic area. Now, pulmonary hypertension with pulmonary regurgitation. Systolic ejection murmur from high pulmonary flow or pulmonary stenosis followed by an early diastolic decrescendo pulmonary regurgitation murmur at the left upper sternal border, a to and fro pattern on right-sided outflow. When you hear flow in both systole and diastole, localize the loudest site, aortic versus pulmonary versus left sternal border, and confirm with echocardiography to identify stenosis plus regurgitation or associated shunts. Now, we will talk about innocent murmurs. Innocent murmurs are short, systolic, rarely continuous, soft murmur. Normal heart sounds and no hemodynamic abnormalities. Venous hum, jugular venous hum, cervical venous hum or Pontane's murmurs are there. Examples of innocent murmurs. Examples: vibratory systolic murmur or Still's murmur, pulmonary systolic murmur, mammary souffle, peripheral pulmonary systolic murmur, supraclavicular or brachiocephalic systolic murmur, aortic systolic murmur, Still's murmur, medium frequency, vibratory originating from leaflets of pulmonary valve, continuous murmur, venous hum or continuous mammary souffle. Now there are some named murmurs. First one is Carey-Combs murmur. Carey-Combs murmur is a soft mid-diastolic rumble due to inflamed metal reflex in acute rheumatic fever. Austin-Flint murmur is a mid to late diastolic apex rumble from severe chronic aortic regurgitation impinging on the mitral valve. Graham-Steele murmur, high-pitched early diastolic blowing murmur of pulmonary regurgitation, classically with pulmonary hypertension. Right-Hand's murmur, atypical mid-diastolic murmur described with complete heart block and slow ventricular rates. Doc's murmur, diastolic murmur reported in association with left anterior descending coronary artery stenosis, coronary blood flow related. Millville murmur, loud splashing auscultatory sound from air in the right ventricle seen after cardiac catheterization or trauma. Now Still's murmur, innocent or musical mid-diastolic ejection murmur at the lower left sternal border, which is common in children, also common with subaortic stenosis or small ventricular septal defect. Next is Gibson's murmur. Gibson's murmur is a continuous machinery murmur typical of a patent ductus arteriosus. Key-Hodgkin murmur, diastolic murmur historically associated with aortic regurgitation, which is described in syphilitic lesions. Roger's murmur, Cabot-Locke murmur. Cabot-Locke murmur is a diastolic murmur heard best at the left sternal border in severe anemia, which resolves with treatment of anemia. Roger's murmur, loud pansystolic murmur maximal at the left sternal border, which is classic for a small ventricular septal defect. Next is Pontane's murmur. Pontane's murmur is prominent cervical venous hum, continuous noted in severe anemia. Next is Cole-Kessel murmur, aortic regurgitation murmur heard in left axilla due to a high positioned cardiac apex. Next is Crowell-Hay-Baumgarten murmur, continuous epigastric or paraumbilical venous hum from portal hypertension with recanalized or paraumbilical veins. Next we will talk about mammary souffle. Mammary souffle is an innocent systolic or continuous cardiac murmur, probably of arterial origin, heard during late pregnancy or in the early postpartum period. It is to be differentiated from pathologic lesions and is unaffected by the Valsalva maneuver. Now, changing murmurs. Changing murmurs which change in character or intensity from moment to moment. Some changing murmurs are Carey-Combs murmur in infective endocarditis and atrial thrombosis, atrial myxomas. Now we will talk about dynamic murmurs. Dynamic auscultation. Dynamic auscultation is a technique of altering circulatory dynamics by means of a variety of physiological and pharmacological maneuvers and determining their effects on heart sounds and murmurs. Interventions most commonly employed are respiration, postural changes, Valsalva maneuver, isometric exercise, post premature ventricular contractions, vasoactive agents like amyl nitrate, methoxamine, or phenylephrine. Now, we will look at the various valvular lesions and their dynamic auscultation findings. The first one is mitral stenosis. Mitral stenosis in the murmur augmenting features are exercise, squatting, amyl nitrate, isometric hand grip, left lateral position or mid diastolic rumble accentuates. Decreases inspiration and sudden standing, mid diastolic softens, opening snap quietens, and A2 opening snap gap widens. Now mitral regurgitation increases in the case of squatting, isometric exercise, left lateral position, which is a hollow systolic murmur, in which case hollow systolic murmur is louder, and in which case does it decrease. Sudden standing, Valsalva, amyl nitrite, murmur intensity falls. Now aortic stenosis. Post premature ventricular contraction beat, squatting, and lying flat from standing, the ejection murmur is louder. And in Valsalva, standing, sustained hand grip, murmur is softens. Aortic regurgitation. Expiration, sitting up and leaning increases. Sitting, leaning forward, squatting, isometric exercise, and vasopressors increase. Early diastolic decrescendo is louder. Amyl nitrate and Valsalva murmur reduces. Mitral valve prolapse. Later click or murmur, squatting, post ectopic beat, isometric exercises. They increase left ventricular volume, which delays click or murmur, and intensity increases. Standing in Valsalva reduces left ventricular volume, which brings click or murmur earlier and is softer. Hypertrophic obstructive cardiomyopathy. Valsalva standing or post ectopic beat, expiration, and amyl nitrate reduce left ventricular volume and increase gradient, which worsens murmur. Inspiration, sustained hand grip, squatting, and methoxamine increase preload or afterload or left ventricular size, which lessens obstruction and murmur. Maneuvers that increase preload or afterload, squatting, hand grip, usually increase regurgitant and many stenotic murmurs, but reduce dynamic left ventricular obstructive tract obstruction. Hypertrophy of cardiomyopathy maneuvers that reduce preload on standing or Valsalva, which accentuate hypertrophy of cardiomyopathy and often reduce other murmurs. Now, usefulness of dynamic auscultation in different diagnosis of valvular lesion. Aortic stenosis versus hypertrophic obstructive cardiomyopathy. On squatting, murmur increases in aortic stenosis, decreases murmur in hypertrophic obstructive cardiomyopathy. So, murmur increases in aortic stenosis on squatting. Valsalva or standing. Murmur decreases in aortic stenosis on Valsalva or standing, whereas it increases in hypertrophic obstructive cardiomyopathy. Now, aortic stenosis versus mitral regurgitation. While using hand grip or phenylephrine, murmur decreases in aortic stenosis, whereas it increases in mitral regurgitation. Post premature ventricular contraction and amyl nitrite are used, then aortic stenosis murmur is increased, whereas in mitral regurgitation murmur is decreased. Austin Flint murmur versus mitral stenosis. Amyl nitrate is used, then mid-diastolic murmur increases in mitral stenosis, which decreases Austin Flint murmur of aortic regurgitation. Pulmonary stenosis versus aortic stenosis. On respiration, murmur increases with expiration for mitral stenosis, which is left-sided, and increases with inspiration for tricuspid stenosis on right side. Now, mitral regurgitation versus tricuspid regurgitation. On respiration, murmur increases with expiration for mitral regurgitation and increases with inspiration for tricuspid regurgitation. Pulmonary stenosis versus small ventricular septal defect. Amyl nitrite is used, which increases murmur in pulmonary stenosis but decreases murmur in aortic small ventricular septal defect. When phenylephrine is used, decreases murmur in pulmonary stenosis, increases murmur in ventricular septal defect. On respiration, inspiration increases murmur in pulmonary stenosis, whereas no respiration variation is seen in ventricular septal defect. Pulmonary regurgitation versus aortic regurgitation. Squatting and sustained hand grip. Squatting and sustained hand grip. Little or no change in pulmonary regurgitation, but murmur increasing in aortic regurgitation. Use maneuvers that change preload or afterload or intrathoracic pressure. Intrathoracic pressure, squatting, standing, Valsalva, hand grip, and amyl nitrate to reveal whether a murmur is left or right sided, flow related or dynamic left ventricular tract obstruction. Now we will see the usefulness of amyl nitrate in differential diagnosis of murmurs. Amyl nitrate systolic murmurs. Amyl nitrate affects murmurs. How? Systolic murmurs, aortic stenosis versus mitral regurgitation. Amyl nitrate increases aortic stenosis murmur and decreases mitral regurgitation murmur. Now tricuspid regurgitation versus mitral regurgitation. Amyl nitrate increases tricuspid regurgitation murmur in right side and decreases mitral regurgitation murmur. Pulmonary stenosis versus tetralogy of Fallot. Amyl nitrate increases pulmonary stenosis murmur and decreases the murmur in tetralogy of Fallot. Pulmonary stenosis versus ventricular septal defect. Amyl nitrate increases pulmonary stenosis murmur and decreases the murmur from a small ventricular septal defect. Diastolic murmur. Mitral stenosis versus Austin Flint murmur. Amyl nitrate increases the mid-diastolic murmur of mitral stenosis and decreases the Austin Flint murmur of aortic regurgitation. Pulmonary regurgitation versus aortic regurgitation. Amyl nitrite increases the end-diastolic murmur of pulmonary regurgitation and decreases the diastolic murmur of aortic regurgitation. Amyl nitrite reduces systemic vascular resistance and shifts blood to right heart or pulmonary circulation, so it accentuates right-sided or outflow murmurs and usually reduces left-sided regurgitant flow murmurs. Use this predictable pattern to help localize lesions. Now, thank you.